Okay, well, thanks for everybody for joining us. So I'm an orthopaedic trauma surgeon based in Birmingham, specialising, I guess, in lower limb trauma and limb reconstruction. And so this evening we're going to talk about open fractures, concentrating mostly on lower limb, but the principles basically apply to all open fractures. It's great to see that we're obviously a very mixed group this evening from different specialties and disciplines and different regions. So this will be very much an overview. There'll be lots of opportunity for questions and discussion at the end. I'll try and keep half an hour in the chat if any questions come up as we go along. So we'll cover a little bit about history and background, mostly talk about overall management principles and how we apply some of the pretty good guidelines that we have in the UK to our sort of everyday practice, and then look at the end at what the outcomes are for these patients and what are the common complications and how we manage them. So this is a quote from 4,000 years ago in ancient Egypt. The mechanism of injury is probably a little bit unusual, living in the West Midlands, but the principle of management has not really changed very much in the succeeding 4,000 years. So any plastic surgeon would be familiar with that concept of an open wound over a fracture requires robust tissue over it for the reconstruction. If we then move forward to 500 years ago, Paré is a French surgeon. Again, the principle is not much different. So he described the need to open the wound up, to remove the foreign material, to allow permanent material to drain. Otherwise, there would be no healing. And again, that's almost exactly what we do 500 years later. Moving forward again to the 19th century, to the major wars, the American Civil War, the Franco-Prussian War, and in the industrial age, the injuries they're seeing them, open lower limb fractures. So you see there's a significant mortality rate associated with these injuries and their aftermath. And then we move forward again to the early 20th century, the First World War. So at the start of the war, if a combatant sustained an open femoral fracture, by the time they'd been transported back to the field units and the military hospitals, the mortality rate was about 80%. And it was the introduction of the Thomas splint, which you can see in the picture at the bottom. So applying early skeletal stabilization, which then stabilizes the fracture, reduces the bleeding, reduces the associated inflammation, and the mortality rate dropped from 80% to around 16%. And it was in the aftermath and the reconstruction of those injuries that Gillies, one of the early plastic surgeons, developed some of the sort of concepts of reconstructions, of using tissue for flat reconstruction to cover soft tissue defects, that then led into sort of our current practice through a process of evolution. And then if we bring it more recently, the Spanish Civil War, Trueta treated a very large number of open fractures there. And he was treating these mostly in plaster, but getting good results just by following the principles of debridement and stabilization. Into the Second World War, antibiotics were introduced. There was some early internal fixation techniques with improved outcomes. And then after the Second World War, so Elizarov was based in Siberia. He wasn't even a surgeon. He was just a local doctor who suddenly found he had large numbers of injured veterans coming back from the war, and he didn't know how to manage them. And he then developed out in Siberia the principle of ring fixation and the bone reconstruction techniques, many of which we still use. And then more recently, over the last sort of 30, 40 years, there have been massive advances in plastic surgery. So in the 70s and 80s, microvascular techniques developed, which allowed plastic surgeons to do free tissue transfers. That's where you take skin and fascia or even muscle with a blood vessel from a completely distant area of the body, and you bring it into a soft tissue defect, commonly over a fracture, and you plumb in the blood vessels to keep that piece of tissue alive. So in terms of the current problem, so this is slightly older paper, but probably gives an idea. So you can see open fractures reasonably common. So 11 to 12 per 100,000. So that translates. So in Birmingham, so we're looking at maybe what, 50 a year. So in the bigger catchment of our trauma network, which has got I guess 2.5 million. So that probably correlates with what we're seeing at the moment. I think there is a typical bimodal distribution of young patients and high energy injuries, and then older patients with fragility fractures, often with a associated wound, but a lower mechanism of injury. We're definitely seeing more of those, I think, at the moment in the aftermath of COVID and what have you, and just a general, I guess, increase in fragility fractures as with an aging population. And as you probably expect, because it's subcutaneous, or because the tibia is a third of the surface of the tibia is effectively subcutaneous, that's the commonest bones to sustain an open fracture. So in terms, in the UK, we've got a number of guidelines to help guide our treatment, and also actually covers everything from how to set up a service, the initial management, pre-hospital, initial management in the emergency department, then the stages of surgery and sort of the follow-up. So NICE have guidelines on complex fracture, which includes sections on open fractures. But in a great example of collaborative working across specialties, the British Orthopaedic Association and the British Plastic Surgeons Society have produced a combined document on the standards of management of open fractures of the lower limb. And more recently, this document, which covers actually all open fractures and goes into a bit more detail, it's definitely worth, if you look at the BOAST guideline from the BOA, which gives a kind of very succinct overview. And then this document goes into much more detail and actually explains the evidence behind some of the guidelines. Although obviously the evidence in all areas isn't that great, but it's a kind of it's an overview of the evidence such as it is, and then a kind of consensus on what best practice is. So it's definitely, if you're interested, worth having a look through that. So I'll just go through kind of how an open fracture would be managed in a UK kind of major trauma centre, trauma network setting. So obviously it starts pre-hospitally, and the paramedics or the medics at the scene. So obviously these patients obviously have multiple injuries. The open fracture might not be the immediate priority, but in terms of the guidelines and the management of an open injury pre-hospitally, so more and more, certainly now, I suspect in most networks now, antibiotics have been given by the paramedics at the scene. And there's really good evidence that the earlier antibiotics are given, the better the outcome. It's one intervention which can make a real difference in terms of long-term infection rates, which are the main thing that we're going to be worried about for this group of patients. Splinting of any long bone fracture, as we saw with the Thomas splint, early splinting stabilizes fracture. Is a good way of relieving pain, but it also, by stabilizing the bone, by stabilizing the soft tissue, you reduce blood loss, you reduce inflammation, which will help not only the injury, but the patient's overall systemic response. Some injuries obviously may be appropriate to apply a tourniquet at scene if there's uncontrollable blood loss. And then there'll be a decision as to where's the best place to take that patient. Do they go to the nearest hospital, or do they need to go somewhere with specialist expertise? And in the current age where we have major trauma centres and a trauma network, so the UK guidelines are that any long bone open fracture or any open fracture involving the foot so by the hind foot and the midfoot, not the toe obviously, but any significant long bone fracture or injury involving the foot should go to an orthoplastic centre. And in everyday practice, that's nearly always going to mean the regional major trauma centre, and that's basically because we've got the right clinicians there in terms of plastic surgeons and orthopaedic surgeons with experience in managing these injuries, but also all the other resources that these patients will need. So physio, they've got other surgical specialists that may be needed. They will have limb fitting service associated if this patient's not going to be suitable for limb salvage. So taking them to that centre is to do with the distal management, but actually the whole package is going to be there to manage them. So the patient will then arrive in the emergency department, and as we said, the initial treatment for many of them is going to be based on an ATLS or ETC approach, managing their life-threatening injuries. And then, so it may not be that the open fracture is the immediate priority, but once we get to the open fracture, so we're going to, again, ensure that they've had antibiotics if they're not been given in the pre-hospital stage, check their tetanus status and give tetanus cover if indicated. The treating team need to document the neurovascular status and assess the compartments in the injured limb to ensure there isn't an impending compartment syndrome that needs urgent decompression. The guidelines, probably in a change from what we used to do in ED years and years ago, is that we don't do any debridement in the emergency department. If there's, a big piece of wood sticking out the leg, yes, we can remove it, but we don't do debridements, we don't do washouts in ED, we just remove gross contamination and then put a saline dressing on after we've documented the wound with a photograph, which then goes into the medical notes. Once the wound is dressed and the leg is splintered, we get appropriate imaging. The baseline would be X-rays. For severe open fractures, it might be appropriate to get a CT angio to assess the blood vessels to the limb, which will help early management to decide if there's any vascular reconstruction needed, but also help subsequent plastic surgical reconstruction if they're going to need to use blood vessels in the leg to help reconstruct the soft tissues. So assuming our patient has then been stabilized in the emergency department, there then needs to be a decision between the between the orthopaedic and the plastic surgeons as to when this patient needs to go to theatre for their first debridement. And in some cases, they'll need to go immediately. So that it's fairly common sense what needs to go first. So if there's a vascular injury and an ischemic limb, that has to go straight away, obviously. If there's a compartment syndrome that needs decompression, well, that's where the muscle compartment's got so tight that the blood supply to the muscle has been cut off. Well, those muscles will die within between 4 and 6 hours if you don't decompress it by opening up the fascial compartment. So that has to go straight away. And if there's heavy contamination, so farmyard contamination, sewage, marine contamination, then those injuries will need to go immediately for debridement and washout. Most injuries, however, don't need to go immediately, and the reason for that is it's recognised more and more that it's better for these patients to go to theatre with in a more controlled way, with surgeons who are fully alert, not at 3 o'clock in the morning when nobody's at their best, and with the right surgeons. So with senior orthopaedic and plastic surgeons with an interest in trauma. So ideally they'll go onto a planned trauma list, and if a patient comes in the evening, it's entirely reasonable for them to go on the next morning's trauma list rather than to go in the middle of the night. And so for high energy injuries, so those young patients with high injuries, they'll go within 12 hours ideally. And for the lower energy injuries and the possibly more fragility type fractures, they'll go within 24 hours. So during that first trip to theatre, there'll be a few things that will happen. And again, this just follows the kind of the principles of debridement. So the first thing to say is it's, as we've said already, it's a senior plastic and senior orthopedic surgeon. So there's combined decision-making as to the best way to treat the wound and to debride it. So we start by extending the traumatic wound along the fasciotomy lines. We'll have a look at them in a minute. And then the plastic surgeon would normally do a sequential debridement of the soft tissue, starting at the skin, the subcutaneous fat and fascia, removing any dead muscle. And then the wound will be extended sufficiently to deliver the bone ends through the wound. And then there'll be an assessment of the viability of the bone ends. So any loose bits of bone with no soft tissue attachments are dead and they need to be removed, because otherwise they'll just be a nidus for infection. And the bone ends themselves are assessed to ensure that they're bleeding and healthy and viable. And basically the bone is sort of debrided back to healthy tissue, just the same as the soft tissues are. And then at the completion of that, then the whole wound will be lavaged with saline. So this is from the Boa Baptist Guidelines. So on the left there, there's a picture of an uninjured leg, but so the green marks in the middle of the borders of the tibia. And then on the left-hand side, that's kind of the medial border. And that mark is where the fasciotomy line is. So if you were going to take this patient to theatre to decompress the posterior compartments, that's the incision that you'd make to get into the superficial and deep posterior compartments of the leg. And those three red crosses, I can just mark them there, those are the perforators which come off the vessel here. And those, it's best to avoid those because they can, these are sort of perforators for those areas of skin, and so you can use that to do local soft tissue reconstruction. So we try and avoid them if we can. And then on this side, this incision is a few centimeters lateral to the lateral border of the tibia, and that's the fasciotomy line that you'd use to decompress the anterior and lateral compartments of the lower leg. And so when we do our debridement, we try and bring our wound extensions along these lines so that if the patient does get a compartment syndrome, you can simply extend that wound to decompress the leg. And then these are, as I said, the perforators on the right-hand side that we need to ideally preserve for our plastic surgical colleagues. And this is what it looks like in practice. So this is a wound. This isn't one of ours, it's just a generic picture, but this is a wound that's been extended along that medial fasciotomy line. You can see the extent of the wound extension that's required to properly be able to assess the muscles and the soft tissues and to deliver the bone end. Okay, so that's typically what a high energy open fracture would look like after debridement. And the bone end is there being delivered and assessed for viability to see if the bone end is bleeding. You get this kind of punctate appearance of red spots on healthy bone when it bleeds. And then it's being washed with saline. So once we've done our debridement, we can classify the open fracture, which does have some uses and gives some ideas to guide our treatment. We won't go into the specifics of this. Essentially, so this is the Castillo and Anderson classification. It was described in the 70s. It was then later on refined. So you can see at the bottom, the type 3 injuries have now got 3 subclassifications. Essentially 3C has an associated vascular injury that needs repair. And those are the ones that have a very high complication rate. But any type 3 injuries, a high energy severe injury that will need, is likely to need reconstruction in terms of either a low flap or skin graft or what have you. The type 1, the type 2 are the possibly low energy injuries. In those cases, the wounds can be closed primarily with simple suturing. And so it may be possible to treat those injuries slightly differently, which we'll come on to. In terms of the lavage, there's nothing clever about that. It's literally just saline. We don't use pulse lavage, which is the kind of a mechanical lavage, because that tends to just drive fluid into pockets and can basically just spread contaminants further into the surgical field. So we just use a simple gravity-fed lavage. There's a fairly recent trial which looked at different soaps and other or antibiotics and what have you, and so on. But basically, normal saline is all that you need for the lavage. There's some debate about the exact volume, but essentially, the more severe the injury or soft tissue injury, the more higher volume that we'd use. So we've done our first debridement with the plastic surgeons. We've extended the wound. We've delivered the bone. We've now classified it. And so, as we said, we've maybe got a Gustila Anderson 1 or 2 where the wound, after it's been debrided, can still be closed. So it can just be stitched shut. And in that scenario, in that first operation, if the wound can be closed with simple sutures, then it will be safe for us to then proceed to definitively fix the fracture at the same time. So that could all be done in one operation. Normally what we'd do, if that was the case, we'd then re-preponderate the limb, start the operation with clean instruments, and go on to fix the fracture, close the wound, and then that's everything done in one operation. For those higher energy Gustila Anderson 3 injuries, that's where the wound, after it's been debrided and all the dead tissue's been removed, there's a hole in the soft tissues, and it's not possible to simply stitch that shut because the wound edges won't come together. So that needs plastic surgical reconstruction. And in rare situations, it might be possible to do that in one operation, but in most units, most of the time, these injuries are going to have a staged approach where you have that first debridement, the leg's stabilized, the wound is stabilized with a dressing, and then you come back a few days later and you do the big kind of 10-hour orthoplastic reconstruction. And so the key principle here is that we never perform definitive fixation when we can't do soft tissue reconstruction. So the definitive fixation and the soft tissue reconstruction have to happen at the same time. We can't have metalwork stabilizing fracture without soft tissue cover. So at the end of that, in that scenario, at the end of that first debridement, we're going to put a temporary wound dressing on. And there's various options you can use. The picture here is of what's commonly called a VAC dressing. So it's a negative pressure wound therapy. So that's like a suction drain. So it's got that kind of sponge in it in the middle there with a suction on, which is attached to a machine. And that kind of sucks away the exudate from the wound. And that's it's a good way of stabilizing a wound, and it gets rid of the exudate. And it's, I think, probably easier to nurse the patient because you haven't got a leaky wound on the leg that needs to be constantly attended to. You can put what's called a bead pouch. That's where you make antibiotic beads with bone cement, or you can just put simple dressings on. There was a very large UK trial a few years ago called the Wolf trial, which compared negative pressure wound therapy with what was described as standard dressings, and essentially found there was no long-term benefit in terms of deep infection comparing the two. So, and obviously a VAC dressing has a significant cost associated with it. So there is no clinical benefit to a VAC dressing other than it makes a wound easier to manage for in between trips to theatre. As well as doing a temporary wound stabilization, we also need to temporary stabilization of the bone or the fracture. And so in nearly all cases, that would be with an external fixator, just a simple monolateral X-fix as shown here. So you can see this is clearly a wound that can't be closed. That's going to need something clever to reconstruct it. So this team is going to come back another day. They've just put a simple monolateral X-fix on. We can debate about the merits of that configuration, but essentially the X-fix is pretty straightforward to put on. It gives you sufficient stability, again, for the patient to be nursed and managed between trips to theatre. And the key thing is that by stabilizing the bone, you also stabilize the soft tissues. And again, that reduces the bleeding and inflammation. And allows the limb to settle so that you can then come back and do the definitive reconstruction. So with our X-Fix, they've not necessarily achieved it here, but we generally try and keep the fixation out of the zone of trauma, so that in this limb, the zone of trauma goes from pretty much the ankle to the knee. So they've kept most of the pins out. Maybe that pins shouldn't be there, but ideally you want to keep everything out of that zone of trauma, so it's all, none of it's been contaminated or interfered with, so that when we come back, that's all amenable to reconstruction. And always, whenever you do any kind of anything like this, any stabilization, always think about what the next operation will be, and try not to compromise the next operation with your intervention. So it's probably a suitable time just to pause and think about amputation, because you can imagine an injury like the one above. There's massive soft tissue loss. Some people might prefer to have an amputation, and in some cases an amputation might be the only treatment option. So in terms of the guidelines, rarely an amputation will be performed as part of damage control surgery. So have a very unwell patient with multiple injuries, maybe has a lower limb injury, the bleeding can't be controlled. The only way to get control of it and properly resuscitate the patient is to do an amputation. Similarly, if you have a severe vascular injury and you've got an ischemia time of more than between 4 and 6 hours, well, the muscles in that leg are going to be dead. If you try and then reperfuse it, all you're going to do is wash, all the potassium and everything that the kidneys and the myoglobins that the dead muscle is releasing, and that's going to kill the kidneys. So an amputation again might be the only option in that case. So those are pretty rare scenarios, but sometimes an amputation would have to be done at that first trip to theatre, because that's the only way to resuscitate the patient. More commonly, we consider amputation as a reconstructive operation. And again, the guidelines are that if we have muscle loss of, say, if we lose more than 2 of the 4 compartments in the lower leg, then that limb's going to have pretty or very compromised function. If there's more than a third of the bone stock of the tibia is lost, then that's going to be a very difficult reconstruction. And so in those situations, amputation should be offered to the patient. And also, if you have, say, an open tibial fracture, but you also in the same leg have a severe foot injury, well, that's a limb that's going to more than likely have poor function and probably issues with pain and long-term disability. And so, again, it's sensible to offer that patient amputation. The decision for amputation, whether that's part of damage control or reconstructive, is multidisciplinary. If it's an emergency amputation as part of that initial resuscitation of a multiple injured patient, then that would be 2 surgeons assessing the limb together and then deciding that an amputation is the only option at that stage. If we're doing a reconstructive amputation kind of in a more planned way, then that would be probably multiple conversations with the patient and the family. And that would involve not only the surgical team, that would involve limb fitting teams. So in our unit, the limb fitting team they're not based in the hospital, but they would come and see the patient as soon as the team decided that amputation was an option for them, and then the patient would be very much involved in that decision. And if the decision following those discussions is that amputation is the best reconstructive option, then we'd aim to do that within 72 hours of the injury, because obviously it's not nice to have that kind of decision hanging over you of what's going to be a major life-changing event. So what are the outcomes if we compare amputation with limb salvage? Well, the answer is we don't have great evidence, but this historical study did try and look at it. So they were looking at kind of the severe, so the Castillo-Anderson 3 injuries, and they compared patients who'd had limb salvage, so they'd saved the limb with orthoplastic surgery, and those who'd had amputation. And so therefore, at 7 years, the functional outcome was the same in both the groups, and it was pretty poor. So less than 50% had got back to their pre-injury occupation. Most had persistent disability. But comparing the two groups, there's not really any difference if you compare amputation with limb salvage. The big difference, and then this is historical, so this is 10 years old, this data, but the big difference was that an amputation cost 3 times as much as saving the leg. And that's because of the lifelong costs of prosthetic fitting. So the function's the same, but the cost to patient or the healthcare system is more with amputation. And then if you go down into kind of the severe foot injuries, again, the if you have a severe foot injury that needs either a free flap or a fusion of the ankle, then those patients have poor outcome long term, difficulty with shoe fitting, etc., and they're probably better off with an amputation. So the evidence to guide decision making isn't fantastic, but those kind of give you an idea of what to expect after those injuries. So if we assume that we're going to go down a limb salvage route, and we're going to do kind of orthoplastic reconstruction of those more severe injuries that need both plastic surgical reconstruction and orthopedics. So again, after that initial debridement, the decision making, certainly in our unit, is very much MDT based. So the orthopedic surgeon and the plastic surgeons work closely together. A lot of the decision making about the timing of reconstruction and the details of the reconstruction are driven by the soft tissue injury. The plastic surgeon will need to decide what tool they're going to use to reconstruct the soft tissues. They might be able to do a simple skin graft, but often in as high energy injuries, that's not going to be appropriate. Sometimes they can find tissue locally, so within the same limb or same limb segment, that they can move around to cover the fracture. But often they're going to need to bring in tissue from outside, so do free tissue transfer from an uninjured limb or part of the limb. And then once we have an idea of what the soft tissue reconstruction involved, we then decide how to stabilize the fracture together with them, and that will be decided by the fracture pattern, whether there's bone loss. But feeding into all of that is obviously the patient factors, their comorbidities, their functional expectations. And so the decision making involves the surgeons and the patient to decide on the best reconstructive option. In terms of timing, we've already said that fixation of the fracture and soft tissue covered by plastic surgeons occurs simultaneously, and the guidelines, based on reasonably good but not amazing evidence, is that that should be within 72 hours. It should definitely be within 7 days, because the rate of the failure of the soft tissue reconstruction goes up dramatically after 7 days. And again, no infix without soft tissue cover. So looking at the orthopedic side, we've got options kind of between whether we go for definitive fixation of the fracture with internal fixation, which gives easier access for plastics because there's nothing in their way. It's easier for the patient because they don't have to live with an external fixator on their leg. And most fractures are amenable to internal fixation, particularly those more straightforward Gastiller and Anderson 1 and 2 injuries, but also most Gastiller Anderson 3, particularly more simple fractures without bone loss. But some patients do need definitive fixation and external fixation, which would normally be a ring fixator, so like an Elizaroff frame or a hexquad frame. External fixation is definitely more flexible because it can obviously be adjusted post-operatively to make corrections to alignment or to compress fracture or distract the fracture. There's a much smaller biological footprint because you haven't got big bits of metal inside the leg. So the rate of deep infection is likely to be less, and certainly deep infection will be easier to treat in the absence of internal fixation. But obviously, you know, most people don't want to have a big thing stuck to their leg for 12 months, 18 months while they have their complex fracture reconstructed. So again, that's the decision for a ring fixator involves, you know, discussions with the patient about the pros and cons. And so in our unit, a ring fixator would be indicated normally in very complex soft tissue injuries, difficult fracture patterns. So if you've got segmental or highly comminuted fractures, and most fractures with segmental bone loss. So this is a open femoral fracture. You see on the left, there's a fairly straightforward fracture there in the diaphysis. You can see the air in the soft tissues because of the open wound. This is a polytrauma patient. This is their sort of trauma CT. They've got a tibial fracture on the same side. So that's been fixed with an intramedullary nail. So internal fixation is completely appropriate for this fracture. And you can see it's gone on to heal uneventfully. The femur has really good soft tissue coverage. It's got big muscles all the way around it. So it rarely needs complex plastic surgical reconstruction. Most defects can be reconstructed with skin graft onto muscle. And this is another example. So this is a periarticular fracture. This is a pilon fracture. You can see the plastic surgeons have done a free flap. These are the Liger clips that they've used as they've done the you can see the outline of the flap there. And then we've used plates and screws for the internal fixation to reconstruct the ankle joint, because that allows us to more reliably reconstruct the anatomy of the joint. So the more challenging situation is when we have bone loss. So we can consider bone loss as, if you think of the circumference of the bone. So if some of that circumference of the bone remains intact, then that's a contained defect. If all of the circumference of the bone is lost, then that's a segmental defect. So a contained defect, some of them, if it's a small defect, you can just observe it and it may well fill in. Larger defects, you could come back and just do a bone graft once the soft tissues have all healed and everything settled down. Or we can use something called a masculate technique, which we'll look at in a minute. The segmental defects are more challenging because obviously there's a whole section of the bone is missing. If that's a short section, so probably up to about 2 centimeters, it may be appropriate just to shorten the leg. Most people can tolerate a small amount of shortening of the limb. They can be managed if needed with a shoe adaptation to balance the legs out. But bigger defects, obviously, you can't shorten somebody's leg by 5 centimeters. Because they're really not going to like that. They're going to get back problems, etc., etc. So in those instances, we do need to reconstruct the bone defect, and probably the most common way of doing that is something called distraction osteogenesis, which again we'll look at in a second. So this was an open distal femoral fracture. Again, there's a polytrauma patient, and so this is a masculate technique. So we've stabilized the fracture, and this area here in the middle of the bone is a bit of bone cement. And what we do is we put that into the hole in the bone where the bone's missing. This was a contained defect. So some of the circumference of the bone was intact, but we put the cement into the defect. And what it does is it essentially stimulates a foreign body reaction. A membrane forms around the bone. And that membrane is full of inflammatory mediators and cytokines, which basically prime it for bone formation. So you then go back in after a couple of months, you take out the bone cement and put in some bone graft, either from the iliac crest or the other femur, and you pack the bone graft into the membrane, and then the membrane kind of, all the mediators in the membrane, in theory, then stimulate that bone to form normal bone. So, and this is what it looks like once it's healed. So it's possibly not quite normal bone, but you can see that defect has filled in. We've reconstituted a cortex there, and it's all healed in. So that's a masculate technique, which is it's good for contained defects. You can use it, or it has been used for segmental defects, but the results are possibly not quite so good for those more difficult defects. So this is how we commonly manage a segmental defect. This was a delayed presentation of an open fracture, and you can see there's a defect in this patient's tibia, which goes from kind of the middle of the bone nearly all the way down to the ankle. So that's probably 10 centimeters of missing bone. And this is definitely someone that we'd discuss an amputation with, because this is a difficult reconstruction. It's going to be in this frame for 18 months, which is, is difficult to live with. It's going to affect all aspects of his life. He's not going to be able to work. But this patient wanted the leg to be saved. So we put a ring fixator on to stabilize the bone. We have put this cable on, and then we've cut the bone up here. And then what we do with the cable, we've pulled the bone apart where we've cut it very slowly, millimeter a day. And you can just kind of see in there kind of some faint wisps of bone forming in that gap that we're creating. So we pull on the cable, we open up a gap at the top, millimeter a day, the bit bone forms in there slowly. And then the gap at the bottom obviously closes up by a millimeter a day, so that after a few months, the gap at the bottom is closed. We've got new bone now forming at the top by what's called distraction osteogenesis. And then this is at 2 years. So we've grown 10 centimeters of bone. The gap at the bottom has filled in and the two bone ends have healed together. And he's now got an intact tibia with essentially normal bone. So that's the orthopedic reconstruction. On the plastic surgical side, they talk about the ladder of reconstruction. So at the bottom, got secondary intention. That's where you just leave a wound and it gradually heals. That's not going to be appropriate for an open fracture, because we want that fracture to be covered with good soft tissue, so we're going to get infection. We've said that some injuries might be amenable to primary closure with direct suturing. We don't do delayed primary closure. Again, we want good soft tissue cover as soon as possible. Skin grafting might be an option. If we've got, you can only put skin graft onto vascularized tissues. So you can put it onto muscle, take skin graft well. You can put it onto periosteum, but you can't put it directly onto bone. And even if you put it onto periosteum, you're not going to get nice, robust tissue over the bone. You're going to get very thin, adherent, non-compliant skin that breaks down very easily. So probably not ideal for that. We don't use tissue expansion for open fractures. We can use local tissue transfer probably for more lower energy injuries, and free tissue transfer is probably now the gold standard for those high energy injuries with big soft tissue defects. So this is local tissue transfer. So there's a defect here over the proximal tibia. This area of skin, you can see that's the blood vessel supplying it. So if you raise that flap of skin there with the blood vessel, it can then be moved across to cover the defect. And then you can skin graft onto this area, which is going to be fascia and muscle. So that's local tissue transfer, taking tissue from the local area and covering the soft tissue defect. So that's obviously, that's great because it's using local tissue. You don't have to take skin or muscle from elsewhere in the body with associated donor side problems. But the issue is, if you have a high energy tibial fracture at this level, the chance it's not just the bone that's injured, it's obviously the blood vessels, the muscle, the fascia, the skin. So this area of skin may be damaged and might not be suitable for transfer. So local tissue transfer may be an option, but more often than not isn't a good option in high energy open fractures. So this is what a free tissue transfer looks like. So this is the flap. So that's probably come from the other thigh. It'll be an ALT flap. Okay, and this incision here is where the plastic surgeons have then found the blood vessel behind the tibia. This flap of skin and fascia has come with its own blood vessel. So it's got a vein and artery that comes with that flap of tissue. And they've plumbed that in. They've done an anastomosis, the pedicle of the flap onto the blood vessel back of the tibia. So that this tissue is then vascularized right from the start. And so that's the sort of commonest way that we would reconstruct a high energy open fracture with soft tissue defect. So free tissue transfer gives immediate vascularized tissue, so it gives immediate soft tissue cover, and it gives really good, healthy soft tissue, and it brings blood supply into the area as well, which helps with the fracture healing. Okay, so that's an overview of kind of the patient journey from presentation to reconstruction. As you can probably imagine, these are difficult injuries and complications are pretty common. So the immediate complications would be compartment syndrome, which we've discussed a little bit, and then infection. So that infection can present early on, can present late. And then we also, later on, we can get problems with bone healing, either delayed healing of the bone or problems with malalignment. And then obviously, there may be later issues with chronic pain, and that can then give impaired function. Non-union, so the LEAP study, nearly a third of their patients had problems with bone healing. That was the higher end injuries, not talking about the more straightforward ones. So this is an open fracture. You can see soft tissue reconstruction here. You can see this fracture has formed bone, so it's trying to heal, but the fracture line is still clearly visible. So that's a non-union of that fracture, which is likely to be causing persistent pain. And when we think about non-union, we think about what are the causes of it. So is the bone infected? There's sometimes infection can drive non-union. We might need to treat the infection or sterilize the bone to get it to heal. The most common cause of bone healing problems is inadequate stability, and that's probably the case in this instance, that the nail isn't providing sufficient stability, so we need to augment the stability. Sometimes there can be an alignment issue, and by realigning or correctly aligning the bone, that will help it to heal. And sometimes there's a biological problem, so because of the open fractures damage the blood supply to the bone, there's not enough blood supply for the bone to heal, and we might need to do something to stimulate the blood supply or stimulate the bone healing organ. Okay, and the other common complication is infection. So historically, in those Gustilo-Anderson 3 injuries, infection rate was kind of anything from 25% to 50%. The more recent series, so if you have a kind of an orthoplastic approach in a dedicated unit to treating these injuries with the resources to do that combined initial debridement and to do the definitive reconstruction with soft tissue and fracture stabilization within 72 hours, then the infection rate in most units is probably between 5 and 10%. So it's certainly better than it was, but it's certainly still a significant problem. And if you have an infected open fracture that hasn't healed, then that is, that's a difficult problem to treat and a massive morbidity for the patient. So this is an early presentation of a bone infection after an open fracture that's been fixed. You can actually see the nail there. That bone is dead. It's definitely not bleeding. Looks like ivory, and you can see the soft tissue defect where everything's broken down. So that's had to be debrided. So we've now got a bigger soft tissue defect. We've temporarily replaced. There's a big segment of bone missing there where we've had to debride the bone back to healthy bone because of the infection. And then this patient ended up needing soft tissue reconstruction and a frame to manage the soft tissue, so to manage the bone defect. So that's obviously a big thing for the patient to go through, and a big morbidity to complication to sustain. Then finally, the outcomes. So again, the orthopedic evidence is probably not as robust as it should be, but recent study or fairly recent study from the Leeds group showing persistent severe injuries. The LEAP group, as we said, their 7-year follow-up. So not talking about these aren't patients who've had complications. These patients who've had either amputation or successful limb salvage, but the majority of them have persistent disability. Many have long-term pain problems, and I think it's about 47% they quoted as had returned to their previous occupation. So, high energy open tibial fracture is a massive injury. It's a life-changing injury, and a significant proportion of patients are not going to get back to anything like the function that they had before the injury. So that's an overview. We've talked really about the basic principles and how we apply them. Probably the themes are around communication. So right from the pre-hospital stage all the way through to the definitive reconstruction and the rehabilitation, and how we work as a team to try and deliver the best outcomes for these patients. And that is me.
Wonderful. Thank you so much, Paul, for such a thorough sort of, I would say whistle-stop tour, but it was a thorough overview of the journey from sort of the initial break all the way through to the rehabilitation of our patients. Now, I'm going to share my screen again, and I do want to point out that the program that I missed earlier is the one that's actually being curated by our own Ian Greaves. So Ian, I do apologise if you're watching for forgetting you. He is our chairperson of trauma care, and I forgot the 7th program is his, which is the ethical and legal program. So before we go to the Q&As, I just want to point out our next webinar, which is taking place on the 27th of this month. So a Friday. It is a classic webinar, which is generally a webinar that isn't available on our website or on YouTube. And it's sort of a catch up on a past webinar with Lieutenant Colonel Mark joining us afterwards to give an update on his work in radiology since the original broadcast. So if you do want to join us for that webinar, do scan the QR code that's on your screen now, and you can catch up on it exclusively on Zoom next Friday. So as we all see, back onto the Q&As. So if you're not a member, please do scan the QR code that's on your screen now, and you can purchase your CPD certificate for tonight for just £1.99. All the money does go back into the charity, which means that we can continue bringing you conferences and webinars such as the one you have seen tonight. We have quite a few questions that have come in. So if people see the questions on the pop on the screen, do shout at me, and I'll take them down again. But because I'm only on one screen tonight, everything's kind of compacted into one. So April asked right at the beginning, just a simple question, which is which antibiotics would you recommend?
Yes, so that has been covered at the bottom. But so most years will have a local guideline, but first line is coamoxiclav as at the bottom there. Yeah.
Wonderful. And anonymous attendee has put, I'm rubbish at feeling distal pulses. Any tips?
Okay, well, just check the anatomy. So realign the fracture first and then assess the pulses. Compare it with the other side. You can get a Doppler, but basically if they're not right, then you have to assume that there's a vascular injury, and then you need to do the appropriate imaging. So don't blame yourself because you can't feel the pulse. So you just need to find out why the pulses don't feel normal.
Wonderful. So Luke has asked, this was slightly covered, but it's more from a paramedic point of view of should they attempt to wash and remove foreign bodies, or is this done after imaging for obvious reasons? I know you slightly touched on it. You did very much touch on it, sort of talking about leaving it till afterwards and not doing it in the ED. So I'm going to assume no. I don't
think you need to do a great deal with the wound other than probably very simple dressing and splinting would be my take on that, and then it can be done in a more controlled environment.
Yeah, and again, this is one that I think was touched upon sort of at the end when we were talking about complications. Anonymous attendees asked about tetanus and when you should consider it, which obviously you did sort of cover that, but I think just a more thorough into tetanus itself. Yeah,
so I'm probably not the person to speak about tetanus, but basically follow the guideline. You need to take obviously a history from the patient as to what their tetanus status is, and then apply your local guideline. But again, it's about low threshold.
Just going to do something very quickly because someone's just said that they can't see the QR code, so I'm just going to ensure that that's up for you. So hopefully you can see that, and do let me know if you can't again, and I will once again jump back on it for you. Simeon, apologies if I pronounced your name wrong there. Open fracture dislocation knee with ligamentous and meniscus injury. As everyone knows, I am not medically inclined at all, so I'm going to say things wrong. What is the best order of management?
So the order of management, so that's a really difficult injury. And again, there's a very high chance of a vascular injury with that. So the order of management would be reduction of the knee, assessment as to whether vascular reconstruction is needed, and then consideration of if there's a vascular injury, needs to do fasciotomies, and then stabilize it with an X-fix, and then you come back and worry about the ligaments and the meniscus and everything later on.
Brilliant, thank you. Anonymous attendees put, if you have a pelvic or femur fracture, should we apply a pelvic binder or traction splint, or both, or neither?
Slightly depend on the mechanism. So if there's I would imagine you're going to need to put on a pelvic binder if you've got a multiply injured patient and a pelvic injury. And you need to splint the femur as well, but it may need to be created to work around. But the pelvic binder should allow you still to splint the femur.
Brilliant. And again, another anonymous attendee is, what is the latest evidence on how soon should external fixation be changed to definitive internal fixation to minimize infection risk?
Well, the pragmatic answer is as soon as possible. So in open fractures, we're aiming to do it within 72 hours. Because that's when we're going to try and get a soft tissue coverage and switch to internal fixation if appropriate. In closed fractures, then you can probably leave closed fractures for 2 weeks before switching to internal fixation if you need to wait for the soft tissues to settle down. But again, you just need to be as soon as possible. And just, I would be worried if it goes beyond 2 weeks, that maybe it's not appropriate to switch it to internal fixation. You might need to stabilize it another way.
Thank you. Again, another anonymous has asked, co-amoxiclav is administered by paramedics. Is it beneficial to administer TXA pre-hospital in open fractures?
Yes, yeah.
Wonderful, thank you. And Danny's asked, what is your thoughts on there we go. What is your thoughts on TXA pre-hospital for single long bone fractures? So yes is the answer, as we just saw. Anonymous again has just asked for the tetanus vaccine guidelines. So I don't know if you can. You said you weren't the best person.
I'm probably a bit too removed from it to give you the tetanus guidelines. Sorry.
Victoria has asked, would you be more likely to allow limb dependency and mobility with a vac dressing versus simple dressing, and does this advantage make the extra cost worthwhile? Apologies there.
Yeah, so for the open fractures, the reality is that during the period that the vac dressing is on, the patient's likely to be pretty much confined to bed. So I don't think it will give you any mobility advantage. Obviously, sometimes vac dressings are used for complex wounds, not necessarily associated with open fractures, in patients who may be more mobile, or even sometimes being managed in the community. In that case, there may be an overall cost advantage to managing a complex wound with a vac dressing.
Brilliant, thank you. And for the person who did ask about the tetanus vaccine guidelines, Joe Hunter has just very kindly popped into the chat a link in there for you to have a look at. And Nilesh has asked, is there open fracture with vascular compromise? Is there open fracture with vascular compromise despite realignment? Should you proceed to theatre or image and then go to theatre?
Yeah, that's a really good question, and it's probably one of constant debate between orthopaedic surgeons and vascular surgeons, because we're like, isn't it obvious where the vascular injury is? I think we probably more than often do get a CT angio, and that's partly because it's just, it's very easy for us because our CT scan is literally 10 yards from ED resus, so you're not delaying by taking them to the CT straight to theatre. It's not causing delay to treatment. But if there's going to be a delay, then you shouldn't get the imaging, you should just go to theatre. But if you can get the imaging without delay, then I think that's reasonable to do, and that's probably our practice.
Perfect, thank you. And Madeline has asked, if the outcome for long-term recovery is relatively low, even in working age patients, what are outcomes like for injuries resulting from fragility? How do you manage rehabilitation of complex injuries in elderly patients?
Yeah, it's a good question. There's probably that's probably an area that's not had as much attention. I guess it's probably not as glamorous as those big sort of reconstructions in high energy injuries. Overall, I think we would recognise that first of all, the elderly patient with fragility fracture, any lower limb fracture, the mortality is similar to the rates for hip fractures. So even an open ankle fracture, the mortality a year is going to be up to 20%, just because of the effect of the injury and the fact that the injury represents a failure of physiology. But in terms of the functional outcome, it would definitely be a decline in mobility. In terms of rehab, so for lower limb injuries, in our unit, probably most units, we would always aim to reconstruct the injury so that the patient would be allowed to fully weight bear and could then start their rehabilitation immediately. If they have a complex soft tissue reconstruction, there may be a slight delay while a flap heals or a skin graft takes, but essentially, once we're happy with the soft tissues, they can rehab straight away, is how we'd approach them.
Wonderful, thank you very much. And just checking the chat very quickly. I think there's just 2 questions popped in the chat, and that's all we're going to have time for tonight, folks. Katie Sloan has asked in the chat, what are your thoughts on rigid neck collars versus self-immobilization?
Again, yes. So again, I'm probably a bit, but self-immobilization seems to be where we're going, and yeah, that would seem to be common sense and good practice.
Wonderful. And Mohammed has asked, with knee dislocation and vascular injury, do you think fasciotomy, is necessary to do before vascular repair? Yes.
So the order ex-fix, fasciotomy, then vascular repair. They can do a shunt if they want, but not a repair. Yeah, the fasciotomy's got to be done early.
Brilliant. Thank you so much, Paul, and thank you everyone for joining us tonight, and for obviously scanning QR code. I'll leave it up for 2 more seconds, and this is your last chance to purchase a certificate if you would like one. And thank you, Paul, for taking the time to answer those questions. Obviously, as always, we do have to thank our wonderful sponsors for trauma care. These are the guys that allow us to keep us going with, you can always see them at conferences. They help us out in allowing us to keep conferences running as well. They are sort of the background lovely people who help us. So the first one is Galen, who, as you all know by now, do produce Penthrox, which is the first line emergency analgesic. As you all probably know, it is the inhaler analgesic, which is now seen widespread throughout sports and all sorts of things. And you pop it, if you watch Emergency 999 on Channel 5, you see it on there all the time as well. If you scan the QR code that's on your screen there, you can go through to watch Galen's CPD webinars as well, and you get an hour's worth of points for each one watched, as you do for tonight. And this is the background of the Penthrox. If you would like a copy of this, please do email me and I can send it across to you. We're also proudly sponsored by Icarus, the power of health. They work all over the world giving emergency health solutions. They also do lovely in-house simulation and travel around giving simulation on emergency bits and bobs there. If you scan the QR code, you can hear more about Icarus and check out their website. It's a really cool website. I love it. And they are one of our wonderful sponsors as well. Also proudly sponsored by World Extreme Medicine. As you all probably know by now, World Extreme work all over the world, especially at the moment in the Ukraine, giving medical supplies and first aid training in extreme situations, whether that's in austere environments, up a mountain, down a mine, all those kind of things. They provide a lot of that sort of emergency wilderness medicine. If you scan the QR code that's on your screen there, you can find their online webinars and their courses that are available as well. They are well worth it and are very, very fun. And I think they do some in collaboration with ATAC, but don't quote me on that. And as we all know, ATAC's courses are brilliant. We're also proudly partnered as an academic partner with the University of Wolverhampton. If you scan the QR code that's on your screen there, obviously, I think ACAS applications are coming up very, very soon. And if you have a child that wants to become a student paramedic or into nursing, scan the QR code that's on your screen there. It'll take you through to their website and you can find out more about the curriculum and see more about the University of Wolverhampton and how they teach, basically. So that's all there is to say from us, and thank you very much tonight, Paul. It was a wonderful, thorough overview of open limb fractures from beginning to end. I'm sure as the chat is reflecting at the moment, everyone has learned a lot. So thank you all for joining us tonight. It was a wonderful webinar. We're excited to get it edited online for more people to see it. Do stay safe, enjoy your evening, your day, wherever you are. We've had people all over tonight, again, as usual, from Greece, the Ukraine. We love to see it. We love being able to sort of educate people around the world. Remember that your voice counts. Stay safe, be kind to yourself. Thank you very much, everybody, and enjoy your evening. Good night.